Good morning, everybody, and welcome to our Point of Care Partners webinar. We're excited you could join us today. We're going to get started in just a minute or two. Just waiting for more folks to log in. Should be just another minute or so. I can see the number rising. All right. I think I'm going to kick it off. Good morning, everybody. My name is Brian Dwyer. I am the business strategy lead here at Point of Care Partners. And I'll be kind of moderating this session. So today's webinar explores a pattern we see over and over again in healthcare policy. Federal action often sets the direction, but states get to work the moment a federal policy gets finalized. This patchwork can be challenging. We'll look at why monitoring both federal and state policy matters, walk through examples in advanced pharmacy practice and prior auth, discuss emerging AI policy trends, and share practical strategies for staying ahead of the changes that can affect your organization. As we go, please submit your questions through using the Q&A feature in Zoom. It's in the menu there. We received a tremendous number of great questions during registration. We'll do our best to address as many as we can during today's session. But if we aren't able to get to your question, or if it deserves kind of a deeper discussion, we'll be happy to schedule time to follow up with you after the webinar. And you can always contact me. My contact info will be at the end. Finally, today's session is being recorded. So after the webinar, all registrants will receive the recording, a copy of the presentation slides, and you are welcome to forward those materials to colleagues whom you think would find them valuable. So with that, let's get started. I'm going to hand things over to Mary Griskowitz, our first speaker today. Mary, please just briefly introduce yourself and we'll jump into the presentation.
Thank you, Brian. Hello and good morning, everyone. Glad to be here. I'm Mary Griskowitz, and I'm a senior consultant with our Regulatory Research Center. Today, we're going to talk a bit about federal and state policy and kind of the levers. The slide in front of you depicts a lot of the activity that many of you, as well as Point of Care Partners, has been involved in actively and continues to track. As we know, the executive branch often would use regulation, executive orders, and members of Congress would use or choose not to use legislation. We've gone from high tech all the way into where we're currently looking at the CMS proposed rule on e-prior authorization for drugs. We've gone through this journey looking through meaningful use, health technology and interoperability 1 through 5, and it will continue. The Cures Act have definitely changed things for us. The CMS interoperability rules, many of you definitely were involved in reading those rules when they first came out. And looking at interoperability overall is something that Point of Care Partners does, and we do extremely well with our clients in trying to help everyone. States often historically would review the federal mandates, and then they would determine if the mandates or guidance were acceptable and right for their citizens or constituents. What we've seen over the years is that states are getting more increasingly impatient. They look at the federal regulations and or mandates, and they say, are these right for our constituents? Are these the right things that we should be doing, or do we need to tighten the requirements? Do we need to maybe be in ahead of federal mandates as we move forward? You know, an example is when we look at prior authorization and the prior authorization rule, is a 3-day turnaround time enough, or really should it be 2 days? We continue to see that tightening. At times, the states do not want to wait. We saw the state of Washington, for example, when the interoperability rule first came out, say, hey, well, we should be using standards. We should be using APIs. We should be using FHIR under those meaningful use regulations, right? So states continue to monitor, get involved, and look at what's best for their constituents. And many of them are no longer waiting for federal action. They're moving forward. So this slide really just kind of gives a timeline and some of the activity that we've seen on the federal as well as the state landscape. The next slide, Brian, moving forward, will depict whether does the federal health IT policy meet the state action. This column, the first left-hand pink column, really represents kind of what was on the previous page, but Point of Care Partners has been really involved in monitoring both the federal and state activity with our Regulatory Resource Center. Our subscriber solutions look at all aspects of the wheel here. We look at the federal health IT landscape and the policy. We look at the state policy through our solutions that we will discuss today, and we work with industry. Point of Care Partners has spent years honing research and collecting data and using quality control processes in order to assist our clients understand where the market is, where federal regulators and legislatures are, as well as states moving forward. And we work as an industry. For example, we are very actively involved in several of what we call the multi-stakeholder initiatives. And we are helping the industry move forward to adopt standards, define standards, and work together through a consensus process. So our subject matter experts are very deeply involved, but we use a very robust QA process to validate what has been going on in the market, what the states are doing, and what regulatory requirements as well as work that is needed to work together as an industry with federal leaders and state leaders to make sure that we have the right information for our clients. So staying ahead for our clients in the work that we do to monitor and detect patterns and recognize those patterns is really beneficial to you and to our clients because it helps you look at your strategic opportunities. Many of our clients, for example, actually do programs software, and they have to adhere to the requirements that are mandated on them. First, they'll look at federal, and now they have to also look at state, and tracking that can be very time consuming. So what we do is we give advice. We look at what's going on in the marketplace, whether it's AI, electronic prior authorization, and we look at those requirements and we try to help you make sense for your strategic planning and how to scale that with your products and services. One of the areas that we've been really most recently involved in digging into is advanced pharmacy practice. And Tony is going to take some time to go over the work and where the industry is at today. Tony? Oh, sorry. I forgot this one slide. Risks and opportunities. I just want to briefly mention as we work with all of our clients, payers, health systems, EHR and HIT vendors, patient and caregivers, right? We look at what the risks are and the opportunities. And again, we look at that going vertically and then across horizontally to make sure that the industry is meeting the mandates. And as part of compliance efforts, in order for readiness to meet those requirements, you need to know where you're at. So you can look at your offense and your defense from a compliance perspective, and then look at how you can be innovative, right? And then how you can bring your products to market. Whether you're an EHR vendor, for example, you could have multiple integration patterns. You can support different channels. You may be looking at what the additional burden or cost is because you're managing multiple versions of your product. And how do you look at the timing? There are opportunities that you should be looking at with a cohesive strategy, and making sure that you have efficiencies in place, as well as how does your product and service stand out. If you're a health system provider, you're going to be looking at where are gaps in care. Is this regulation going to help us close those gaps? Or are they going to widen gaps? Is it going to lower the quality of care for our patients and their families? Or is it going to actually advance healthcare practices and services? What are those opportunities? And in particular for the payers, we know that a lot of the regulations around interoperability and standards have been time consuming. They've been a lot of work with regard to volunteering, to resources, but really helping your clients, right, and those that you serve to close those gaps in care is really key. And what are the best ways that you can do that? Are there opportunities for you to think of your services and solutions a little bit more holistically, and that could help strengthen your brand. So planning for all of this is really, really important. And now with that, I'll turn this over to Tony so he can do a little bit of a deeper dive into advanced pharmacy
Thank,
practice.
thank you, Mary. My name's Tony Sheath. I'm the CEO and managing partner of Point of Care Partners. I'm also the publisher of the Regulatory Resource Center. I've spent my career in health IT and spent a lot of time in pharmacy. The reality is that we have an underutilized asset in the U.S. healthcare system, more specifically pharmacists. Since 2003, pharmacists have been leaving pharmacy school as doctors in pharmacy. They receive significantly more education and training in medication-related therapeutics than other clinicians and are trained in pharmacokinetics, pharmacodynamics, drug interactions, adverse event management, and clinical therapeutics across different disease states. In summary, the majority of PharmD training is dedicated to the effective, safe, and evidence-based use of medicine. Without a doubt, pharmacists have increasingly become part of a multidisciplinary healthcare system. In pockets, this has translated to the broader community where they have increasingly become part of a broader healthcare team under a collaborative arrangements and other overseen by physicians. While some states have been coming around to this expanded role, the reality is that pharmacists have largely been viewed as dispensers. At a time when we have provider shortages, expanding healthcare costs, and increasing burnout, pharmacists are increasingly being viewed as part of the solution. This particular slide talks about COVID because really, COVID changed everything. During the pandemic, many states granted pharmacists the authority to administer vaccines, and schools of pharmacy began teaching it. After the pandemic, many of these temporary authorities were made permanent, and the states began actively considering further expansions of the pharmacist's role. This shift has elevated pharmacy practice from a peripheral vision and function to a central component of the healthcare delivery system. No one wanted the pandemic, but the crisis showed that we can truly accelerate policy changes and serve as a catalyst for long-term transformation. For different stakeholders, this evolution presents both opportunities and challenges, as they must manage risk by adapting to rapidly changing regulations while leveraging expanded capabilities to improve patient care and operational efficiency. If you can go to the next slide, please. So states took the baton. Following the pandemic, states assumed a leading role in shaping pharmacy practice policies. However, the reality is that there is variability across jurisdictions with no single nationwide answer to what pharmacists are permitted to do. Instead, scope of practice rules differ significantly depending on the state, including authority for prescribing, test and treat capabilities, collaborative practice arrangements, vaccine permissions, chronic disease management, to name a few. These variations create both risks and opportunities for organizations operating in multiple states. On one hand, assuming that federal compliance equates to full compliance can expose organizations to regulatory violations at the state level. On the other hand, understanding where states have broader authority allows stakeholders to expand services strategically and gain a competitive advantage. Stakeholders must develop systems to track, interpret, and act on state policy changes to remain compliant and competitive. The reality is that complexity is a defining feature of modern healthcare regulation and sets the stage for discussing why such complexity matters strategically. Can we go to the next slide, please? So, why does this matter now? Developments in pharmacy practice impact broader strategic trends affecting healthcare organizations. State policy evolution is no longer a niche concern, but a central factor influencing key operational areas such as rural health access, workforce shortages, value-based care, and reimbursement models. Expanded pharmacy authority is increasingly being leveraged to address provider shortages, particularly in underserved areas where pharmacists are more accessible and aligns with initiatives from federal agencies like HRSA and CMS. Additionally, pharmacists are becoming integral to value-based care strategies due to their role in improving outcomes and managing costs through medication optimization. This slide also introduces emerging models such as the Pharmacy Health Reimbursable Medical Services or PHARMS model, which could further integrate pharmacists into reimbursable services under Medicare. Importantly, state-level policy changes generate evidence that may influence future federal reimbursement decisions. This creates a feedback loop where state innovation drives national policy shifts. Organizations that understand these dynamics can proactively design programs that align with future policy directions. This slide reinforces that policy monitoring is not just about compliance. It's a strategic function that can influence growth, innovation, and long-term success in the healthcare sector. Let's go to the next slide, please. So for a pharmacist to be authorized to prescribe selected drugs and get paid for them, they need to be defined as a provider in that state. This slide illustrates where Medicaid recognizes pharmacists as providers in addition to pharmacists' ability to bill for DME products under Medicaid. In the commercial insurance arena, pharmacists have positioned their request for payment of non-dispensing services by using this argument that Medicaid accepts them as a provider for coverage. Still, individual community health plans have authority to consider pharmacists as a provider and then be able to pay them for their services. Every state has one or more method to grant pharmacists prescriptive authority. This includes standing orders, protocols, and specific collaborative practice agreements between pharmacists and a physician. This breadth and depth of these means of prescribing are controlled by a combination of state laws and authorized regulatory bodies such as boards of medicine, boards of pharmacy, and other agencies. So at this point, I'd like to turn things over to Keith, who will introduce himself and show you our advanced pharmacy portal. Keith?
Good morning. Thank you, Tony, for that kind introduction. And let me first point out a couple little housekeeping pieces here. First of all, I'm going to share my screen momentarily here to show you a little bit about how we manage some of this content. But first, a point of introduction. I'm a senior consultant and a pharmacist here as in Point of Care Partners. I'm also the co-editor of a regulatory resource center for the various different solutions that we produce here. But my career has been current of deciphering all kinds of laws and regulations and then trying to operationalize those within the particular systems that I've been engaged with over time. So with nothing more to do, if I'm doing this correctly, I should be sharing my screen right now. Pharmacy advanced practice product managers need to identify and track the new and changing federal and state statutes, regulations, and guidance documents in this area of advanced pharmacy practice. These teams need to search the state legislatures and various boards of professional practices for new materials on a constant basis. Then the product managers need to evaluate the potentially applicable content, filter out those that are not applicable to healthcare. Then they got to tag and monitor the relevant items until they are enacted or adopted. These additions and changes should then be recorded in some sort of a database so that folks can refer to those and implement and remain compliant with all these states and laws and regulations as they codify their systems. So now let me show you how we here at Point of Care Partners organize the results of this very time-consuming hunting and processing of relevant and actionable material for our customers so that they can, in fact, remain compliant with all of these laws. So let me show you how we do this. This is a various different application here specifically for pharmacists advanced practice management. And as Tony was talking, he mentioned that there were certain things that individual states are trying to enable the prescribing of pharmacists. And they do that via collaborative practice agreements. They do that among standing orders. They do that among protocol situations here. And as you can scroll through these various different states, you'll see there's a lot of variability between who's doing what pharmacists are permitted to perform, and how they're supposed to be doing them. Many states now are dealing with capability of emergency refills. Are you tracking those in your particular system to allow for pharmacists to essentially create a one-time prescription for another month's supply of a particular product because the patient's standing at my counter and they're demanding a refill and I can't reach the doctor to get an authorization? What are several of the components that are being used under protocols that the states are defining and sharing amongst the various different states? There's a bit of a collaboration between the several states. So as an example, if they're going to be looking at HIV PEP and PrEP preparations, how can pharmacists facilitate the prescriptions of those particular products? So let's take a look at a specific detailed example here. Let's just click on and go see what Arkansas specifically is doing here. So in the case of Arkansas, we can see that here's some of that content that we were seeing. Vaccinations and contraceptives are allowed to be prescribed, but there's some limitations on what the pharmacists need to be aware of. These do differ state to state to state. So this is a means that you should be tracking how you're allowing it and what are the limitations that you should be building into those particular applications. But many people then want to be able to see, well, what's the exact language that the states and the organizing bodies have that facilitate this content? You need to be able to see, well, what are some of those guidance documents that boards of pharmacy, boards of medicine, boards of nursing, and other relative agencies are publishing to produce, here's the exact protocol. So the other thing that you might want to be looking at that you do need to be looking at is, you scroll down through here, then you will see here we go. We actually publish here for you the statutes. These are the laws that are dictating what can and cannot be done. And it's just as important for what cannot be done as what can be done. And then finally, the last piece of this puzzle is the various different agencies come about here, the Board of Pharmacy, and publish the regulations that support all the statutes that have been enabled. So we encourage our clients and everybody out there to basically be able to monitor these state laws and regulation variances, be able to organize them in some fashion, and then be able to present them to your product teams so that you can implement state-specific capabilities and prohibitions appropriately. So with this, I'd like to turn it over to Kendra to discuss some of the prior authorizations and some federal-state relationships there.
Great, thanks, Keith. My name is Kendra Obrist. I'm a senior consultant with Point of Care Partners. I've been with the firm for about 13 years and focus my energy primarily in the payer segment and the technology vendor community that serves the payer and provider markets. I'm going to spend a few minutes talking about some federal and state regulations, starting with CMS 0057, the final rule, which I'm sure all of you are familiar with. One of the key focuses of that was the inclusion of several new APIs, including the API for electronic prior authorization, some updates to turnaround times and transparency requirements, but importantly included two new APIs, provider access and payer-to-payer, and an expansion of the requirement under the patient access API that was mandated by CMS 9115. The breadth of these requirements and their focus on FHIR, which I think made the industry at large sort of accept the fact that FHIR was here to stay, have caused impacted organizations to make fairly significant investments in their FHIR-based infrastructure as they anticipate, and we're seeing their further regulation happening and a further dependency on FHIR to be compliant. As a matter of fact, many organizations basically scrapped what they had done for 9115 and have, in essence, re-implemented the patient access API under a new and expanded FHIR infrastructure that they intend to be sort of their future going forward. The expansion of this and the investments that are being made have caused these organizations to really think more strategically about this investment. How are they going to realize the value of the investment as we enter the second half of 2026 and have the implementation of the API's deadline sort of sitting in front of us on January 1st of 2027? Many organizations are saying, okay, I just invested a ton of money here. How am I going to realize the value of electronic prior authorization? What is the payer-to-payer exchange of data going to be able to do for me and help me improve my business and my members' health? And then the industry actions around the prior authorization pledge and the health tech ecosystem are, from an external factor, really putting sort of more and more emphasis on interoperability as a whole, and how the industry can come together to solve the challenges that we face. You can go ahead and go to the next slide, Brian. So that was sort of federal regulation in sort of recent years. What are the states doing? So, states have long had regulation around prior authorization that predated CMS 0057. Mary mentioned the Washington state regulation, which actually had an implementation date of January 2026. Originally, the state did then align that with the January of 2027 date for the federal regulation. They do, though, include drug prior authorization in their 2027 requirements, unlike the federal regulation. And I'll talk about CMS 0062 in just a couple of minutes. So the state legislation has largely focused historically on turnaround times, transparency, then moved to gold carding. I think, it's important to know that each state does things differently, depending on their legislative priorities. They may have more or less of a focus on different aspects of prior authorization, or no focus at all. You can see from the map that is shown here, there are 8 states that are shown in red that actually have passed gold carding. None of them are the same. They all have different thresholds, and gold carding means different things in different parts of the country. So some states, you'll see many had failed, actually have prohibited gold carding. So some require it, some prohibit it. The states are sort of all over the place. Florida, limits prior authorization for certain medications and treatment areas that the health plans that operate in the state of Florida, which just happens to be where I live, are prohibited from having prior authorization requirements for certain meds. So it's important to monitor this. I think when I finish this section here, Keith is going to spend a little bit of time and show you sort of the way that Point of Care Partners monitors the electronic prior authorization requirements on a state-by-state level. Go ahead and go on to the next slide. All right. So let me just speak for a minute about CMS 0062, which is a proposed regulation. It is focused primarily on adding drug prior authorization to the 0057 requirements. As you can imagine, there's some complexity there because of the intersection with the NCPDP script standards. It also makes some modifications around timelines and transparency. It's anticipated, as states have done in the past, that there will be state-level reactions to this, where they may tighten certain policies around turnaround times or transparency, they can be more restrictive than the federal regulation, but not less so. Federal public commentary was due for this on June 15th. That commentary can be found online at regulations.gov if you want to read through it. Point of Care Partners also did a webinar in May of this year that is available on our website, POCP.com, under insights and webinars and presentations. If you want to look at sort of our deep dive into the reg and some of the information seeking aspects of 0062. With that, I will turn this back over to Keith, who is going to walk through the PA Navigator.
Thanks, Kendra. Welcome back, everyone. So before I start to show you how we organize it, just a couple thoughts here. There are certainly some unique things that prior authorization product managers need to monitor, in addition to the actual statutes, the regulations, and the guidance documents that we showed you here. So first of all, there's a huge difference in maturity between the pharmacy prior authorizations within the pharmacy benefit specific to Medicare Part D, as well as in what's going on with the medical service prior authorizations. And Kendra mentioned many of these particular nuances that are out there. So we've decided we need to kind of track those separately. Like I said, Medicare Part D is in place for prescription drugs covered, but it's only for those areas that are covered under the Medicare Part D plan. So the point to keep in mind here is that that's the law actually in every state and territory, again, for the covered Medicare Part D plans. But if you are not prescribing under a Medicare patient or Medicare plan, then that's where we need to kind of look at the laws and the regulations on the commercial side. So many of the states have a benchmark that they use as a model for deployment to the commercial health plan. They use that Medicare plan, if you will, but here are some of the different options that they try to deploy on the various different approaches. Mary and Kendra spoke about a couple of these. So one of them, sometimes a state will copy as is the Medicare Part D guidelines for commercial use. Other states are going to rely on a voluntary use of the Medicare Part D approach within their commercial plans, but they won't mandate it. And then others of them will use Medicare Part D as a base under the prescription drug program as an example, but then they alter and tweak it for their commercial applications. So the prior authorization management team members need to be able to see the relevant content that is both current and comprehensive. So with that, I'll show you a little bit about, again, how we organize some of the content here. So this is a solution that we have related to prior authorizations. And so let me first of all take you to the more robust one that's already available here. That's the pharmacy laws and regulations that are in place. So first of all, since we mentioned federal is the CMS content is a baseline. It's the law for Medicare Part D everywhere. We think the product managers need to be very aware of and understand, well, what is required under the Medicare Part D rule, so that you can use that as a baseline to compare and contrast the various different states and how they are similarly reacting to this content. So this is pharmacy. Notice that even though Medicare Part D says the 24-hour, 72-hour turnaround times for urgent and non-urgent, these differ at the various state levels. On the commercial side, still the law for Medicare D, but you need to be able to track what's going on in the various states when you're dealing with the commercial side. Also, take a look at, in this particular case, the standards that are applicable here. Since this is a mature application for pharmacy benefit Medicare Part D content, most of the states have codified that you got to use the same standard that is being used for Medicare, NCPDP script standards. Some of the states don't define it. They just leave it up to whatever the voluntary use of those standards are, which of course are already codified towards NCPDP. So the other thing that we need to take a look at is that let's take a look at Michigan as a classic example here. Michigan is, here we go. So if I click on and look at the details around Michigan, then we're going to see that there's a couple different things that we're monitoring here. We're going to separate things, and you should be doing the same thing. Separate the prescription requirements from those that are dealing with the medical transaction requirements. In the state of Michigan, you'll see that this is similar to what we were just talking about with the NCPDP. Again, some various different nuances here. Got to be aware of, but on the medical side, this is the X12 standard. And what's the current status here? So all this content, you should be organizing this. You should be looking at it so that you can have relevant content to provide to your associates. Similarly, like we did in the prescription pharmacist prescribing capabilities here, we're going to provide you the guidance documents, and we're going to provide you statutes as well as regulations if there are any. But we're also dividing this up between the prescription content and the medical content. So you've got different rules, different standards oftentimes, different statutes. Many times they're very similar, but you need to be able to track those as they are in fact different. The last thing I want to point out here, in the state of Michigan, there are no pending legislations that's being proposed and discussed right now at the legislative site. If there are, we would provide that to you as well so that you can see what is actually being debated and potentially in the future for the various different applications. And just as an example of that, real quickly, let's look at the medical proposed report. See all this content, a lot of activity that you guys need to be monitoring on what's going on at the various state levels. Lastly, what I want to show you, let's go back over here to Michigan. Kendra mentioned gold carding. Gold carding in many states, in some states it's just open-ended. Many of the states publish the exact approval percentage, the evaluation period, the exemption and durations. So as an example, you have to look back 2 years and a provider has to have 90% approval rate. And if they have 90% approval rate, then they're deemed to be approved. They don't need to get a PA approval within their particular discipline. And then we provide the individual similar legislation, regulations, if appropriate, etc. So with that, let's go back to Mary and see some of the unique characteristics related to artificial intelligence.
Thank you, Keith. I appreciate that. Well, Brian brings up the slides. When we look at artificial intelligence, we have to look at it from two perspectives, federal and state. What we've actually seen here is truly a shift. The states are actually leading versus the federal government. The federal government has basically said that they would like the industry to innovate. Hence, they really have been choosing not to put forward a lot of regulation. They've been using their executive order privilege to come up with some high-level frameworks, some requirements of what they think the federal government could be doing. If we look at the most recent executive order, and particularly around security, it's really focused at the federal level and asking the federal government to look at putting together some infrastructure in place to make sure that we continue to be secure from a cybersecurity perspective, more of a protection position. But this should also help, I will say, some rural hospitals in particular, and those hospitals that may have some issues with resources, because it is going to be creating somewhat of a clearinghouse type of perspective of making sure that we can look at testing and working with our federal agencies to protect the information. But the main point here is when we look at things, whether it came from 21st Century Cures, CMS 0057, HTI, we've seen in the past the federal government really moving the ball and then influencing the states. Now we're seeing a little bit of a change. We're actually seeing the states that are leading on artificial intelligence. So the posture towards innovation for regulation is a little bit different, and it kind of opens the field a bit. We're seeing some things around clinical decision support and privacy, in particular, if you're working with the Office of the National Coordinator, that still tends to be, top of mind, making sure for clinical decision support that there's always a human in the loop. But the states are really looking for how do we correct this balance. If we can move to the next slide, Keith. This slide really looks at that friction, right? It looks at federal government saying, hold back, please, states. In one of their executive orders actually mandated that states do not pass legislation. However, they don't have the authority to do such. And state authority is very different because they're going to be, again, looking at what is right for their constituents. In 2025, we saw 47 states introduce about 250 AI bills. That's quite a bit. Earlier than that, we actually saw some very bad bills, I will say. NCLS actually came up with the model bulletin and others, and we've really been trying to help state legislatures come up with where they should be looking at passing legislation. And what we've seen is a change, right, from some of that early language. In 2026, we saw 43 states introduce about 240 bills. And the range goes from mental health and particularly protecting children and looking at the use of chatbots. For example, California, Nevada, New York, and Michigan were some of the states that introduced those. Clinical oversight and safety and consent of AI continues to be a big issue with the states, really making sure that licensed clinicians are involved. There's that human in the loop, again, making those decisions. The providers are doing so, and that there's some transparency in how decisions are made, and transparency on if you're using AI, how is that actually being accomplished, and being transparent with the patient, with their families, on how those decisions are made. For example, I recently went to the dentist. I had to get something looked at. I sit now in the state of Florida, and the dentist had to disclose to me that he used AI in helping to examine the x-rays. And he asked me if I knew what it was, and I explained to him, yes, I did. But he wanted to make sure from an education perspective, through transparency, through disclosure, I understood the use of AI in his recommendation back to me. That is really what the states are looking for, in making sure that the providers, as well as all companies using AI, are very transparent in how they're using the information. We're seeing transparency in accountability of the algorithms overall, making sure that there's documentation on models, payers' use in particularly of AI. We talked about gold carding before, and we talked about prior authorization bills that we will see continue. We continue to see payers in particularly looking at the use of AI and how it could help them, making sure that folks are not upcoding incorrectly, and how claims are processed. We see states in particularly even looking at creating sandbox so that they can do learning on how to use AI, whether we're looking at Utah, Texas, Delaware, California, all have stood up sandboxes, and they have legislation on how to do that. So we're going to continue to see the states. Many of them, as you know, are on recess at this point in time. We're looking at seeing what will happen for next year when we look at the states that have been the most active. We can only expect next year to be around artificial intelligence to be even more active. 33 states have really adjourned and dined right now, including Louisiana, and we expect New Hampshire to adjourn today. There are 4 states that didn't meet in 2026. So what are they going to do in next year? And there are a couple of states that have adjourned to the call. So this is an area where we've seen that shift. The states want guardrails. They want their constituents protected because of the lack of federal government regulation, legislation. Right now, Congress is continuing to follow the lead of the president in what they're doing. So please, keep this in mind. We can help you with this. We will continue to help you do that. And this is, again, just a summary, of those key areas. And I ask you to think about these. How are these areas important to you and your company? How are they going to impact you as you move forward? So with that, Brian is actually going to take some time and he's going to share with you how we think that could get accomplished. Brian?
I'm back. So we've spent the last 3/4 of an hour or so talking about why this matters. So the obvious question becomes, what do we do with this? There isn't a single technology or a single policy that solves this challenge. What organizations need is a repeatable capability for understanding change, responding to it, and improving over time. It starts with understanding where you are today. What regulations apply to your organization? Where do federal requirements intersect with state requirements? What capabilities do you already have? And where are the gaps? And that's the foundation for every good strategy. From there, you can develop a roadmap that treats compliance as more than a box to check. Every regulatory project is also an opportunity to build infrastructure, improve workflows, strengthen interoperability, or create capabilities that support future initiatives. The organizations that get the most value out of these investments are the ones that think strategically instead of approaching every new rule as a fire drill. Then comes execution. So who on your team already has the expertise? Where do you need outside partners? What work should stay internal? What makes sense to outsource? And just as importantly, how are you going to bring your organization along? Because technology projects don't fail because the technology doesn't work typically. They fail because people aren't aligned around the change. And finally, this isn't a project with an end date. The policy landscape will continue to evolve. New federal rules will be released, as we're seeing. States will continue to legislate and issue guidance. Success comes from building governance and continuous improvement into the process so that your organization gets better each time instead of starting from scratch. And this is where Point of Care Partners works with clients every day. Some organizations need help understanding the landscape. Others need strategic planning or implementation support or ongoing program oversight. We help each stage because because these aren't isolated activities. They're all part of building an organization that's prepared for what's next. So that brings us to the final piece of the puzzle. Everything on this slide assumes that you know what's changing. Before you can build a strategy or execute against one, you need a reliable process for monitoring state policy and understanding which developments actually matter to your organization. And that's what our last slide is about. So on the left, he's got a checklist basically for monitoring the federal and state policies that are relevant to your organization. So you need to identify a reliable and trusted source for the information. You got to be proactive. You can't wait for the laws to be signed. You have to know kind of what's further down the road and avoid surprises. You've got to test and confirm the criteria. Mary talked about QA. Just using AI, for example, will not yield necessarily the most accurate predictions of what's going to pass or what has passed. And you need to create a tracker that's formatted in a user-friendly way. So in short, it's a lot of work to keep up with what's happening in AI, what's happening in advanced pharmacy practice, prior authorization, e-prescribing, et cetera. So you can invest all of that work, or as we've Keith was showing you, you can skip all of that and subscribe to our Regulatory Resource Center subscriptions, and you can contact me at the end of the webinar if you'd like to explore that. So with that, we're going to go into Q&A, and I think, let's see, we've got some questions here. And I think, well, what's the time check? We've got 10 minutes. So here's one question that came across. What percentage of health plans are actually going live with CMS 0057 on January 1st? I think I will send that. Kendra, would you mind commenting on that?
Sure. As you can imagine, health plans are not publishing whether they're planning to go live or not on January 1st. And I would say that the majority certainly are planning on. There are certain plans that were able to file for exemptions or delays, and many did that and are unlikely to go live when they're not required to. But I would say the vast majority of health plans are on target to go live with the basic capability. Is it going to be what it will be in 2 or 3 years? No. But I think meeting the letter of the regulation, the majority of health plans are ready or will be ready.
Okay, thanks, Kendra. Appreciate that. Let's see, another question here. What are ways that states might work together to synchronize their health data policy efforts? That sounds to me like a Mary question. I'm gonna throw it over to you, Mary. Can you comment on that?
So yeah, many of the states have been working together with their communities, whether it's the payers, the providers, the health information exchanges in particular. Massachusetts Health Data Consortium is a great example of that. They've actually created their own health data exchange network. They've been monitoring the regulations for interoperability in the rules. They provide public comments. They actually do live testing, with their plans in the environment, just as an example. There are others, such as Washington State, that have been working together. And they've been looking at the interoperability rules, and Kendra may want to comment on that a little bit more. But bringing in your partners in the ecosystem is very important. I even talked a little bit about the sandbox, right, around AI. So the way you get that is you get the states to kind of approve at the higher level, right, the sandbox in which you can exchange information or test your products or services, your hypothesis for using the technology and the standards. The state of Utah is doing that, and particularly we saw Doctronics using AI. You can kind of read about that, and it goes up and it goes down as far as who likes it, who doesn't like it. But, states are looking, the state of Michigan had their own sandbox as well. So states are looking for partners, and they're looking to make sure that innovation takes place within their states. The state of Colorado has their own, health informatics innovation area. So that's something, in particularly as we see more and more requirements because of the lack of funding with the states. The states are looking to use technology to advance how they can exchange information and be more nimble overall to serve their constituents. Hopefully that helps.
Thanks, Mary. Okay, I think with that we'll kind of wrap up the presentation. We want to thank everybody for registering and participating in the webinar. If you have questions that come to mind after the webinar and you'd like to discuss them with us, please feel free to reach out, or if you're interested in learning more about our Regulatory Resource Center subscriptions, reach out to me. My email is there. Brian, you can actually just do brian.dwyer@pocp.com, but you can also use Brian J. And I'll be happy to chat with you about it. So with that, thanks so much, and have a great rest of your day.